Okay, Olivia, I'll be doing an assessment on your hair. I'm going to be checking to see if there are any infestations. Okay, turn this way for me, please. Just making sure my instructor can see what we're doing. Okay, so there's no infestation. I'm going to palpate your scalp for any lesions and tenderness. Does it feel tender? Does it hurt? No. So there's no lesion or tenderness, no infestation. Her hair is black, thin, and there is no receding in the hairline. Okay, all right. So next, Olivia, I'm gonna be doing your skin, okay? So let me just take a look at your skin. There is no nevi, no burnt mark, no lesions. Let me look at the back. Okay. And skin is intact. Skin is warm and dry, cool to touch. Sorry, warm to touch. Okay. All right. So next, Olivia, I will be doing your. So I did your skin and hair. I'm gonna do your nails. Okay. Can you uncross your legs? Okay. So your nails, the nail beds are pink. I'm gonna do capillary refills on them. Capillary refill is less than 3 seconds. Nail beds are pink, no sign of cyanosis noted. Nail beds are intact. I'm going to check for clubbing. I needed to just do this for me, Olivia. Sorry. Okay, and we're just checking to make sure they line up and they are. Okay, so clubbing, there's no clubbing there. All right, let me assess your toenails, pink and warm. I'm gonna do capillary refill as well. Capillary refill. Sorry, skin turgle. Checking for skin turgle and good recoil. Okay, so I assess your skin. Okay, all right, so you're gonna look in a distance while I examine your eyes. I'm gonna find a red reflex. I'm gonna find my landmarks. Going from the outer canthus to the middle of the eyebrow and then down, and I should see the red reflex. Okay, red reflex present. Okay, I'm gonna come to the other side and I'm gonna do the same thing. So I'm gonna find my landmarks, the outer canthus, move to the middle of the eyebrow and then down. And there I'll see the red reflex. Okay. Okay, thank you, Olivia. Okay, so I do everything for the eye. I did the cover and cover test, accommodation, 6 feet of vision. Okay, so now I'm gonna examine your ears, okay? So I'm gonna do the left ear. So first I'm going to pull the pinna up and okay, and the tympanic membrane is intact. All bony landmarks are intact. Tympanic membrane is pearly gray, and the cone of light is at 5 o'clock. Okay. All right. There is no drainage, no erythema, no bogginess, no. Okay. All right. So now I'm gonna do the next ear, and I'm gonna change my cover. Okay, we're gonna do the same thing here. Okay. So I'm gonna eardrum is visible. The tympanic membrane is pearly gray. There is no drainage, no erythema. The bony landmarks are intact, and the cone of light is at, I would say, 6 o'clock. Okay, all right. Okay. All right, so next I'm going to, or I should have examined the outside of your ear to palpate to see if there's any lesion. Does that hurt? And the pinna is intact, in line, sorry. Let me do the other one as well. Palpating, is there any pain? No, okay, so there's no lesion noted on here. Okay, all right, so for the ear as well, we have 2 tests that we can use to test for hearing loss, and we call one of them the Weber test. I'm gonna hit and I'm gonna put it on here, and then you will tell me, not when the sound stops, you're gonna tell me when you're not, if you're hearing it in both ears the same, okay? So I'm gonna hit on here, put it here, and tell me if you hear from both here equally. You're hearing from both ears equally? Okay, good. All right. So, negative Weber test. Patient was able to hear the same, this from the same, both ears the same. Okay, so next we're gonna do the reading test, and I'm gonna hit as usual. I'm gonna put it on the max side process here, and you're gonna tell me when you stop hearing it. Okay, as I time my watch. Okay, so that was 6 seconds. Okay, now I'm gonna put it here now, and you tell me if you hear it still. Tell me when you stop hearing it. Okay, so that's about 16 seconds, which is accurate because normally it's a 2-to-1 ratio where air conduction is greater than bone conduction, and we're going to do it on the right ear now, okay? Tell me when you stop hearing it. Okay, so that's about 8 seconds. Okay, 20 seconds, which is roughly the same 2-to-1 ratio where air conduction is greater than bone conduction. Okay, so we did the ears and the eyes. Okay, now we're gonna do the nose. I'm gonna put a different cover on here for your nose. I'm gonna have to look inside your nose too, okay? Your nose. Okay, so there is no septal deviation. Mucous membrane is pink and moist, and septum is midline. Can you breathe through this nose alone? I'm testing whether the patient can breathe through one nostril. Breathing okay? Okay. All right. So next, I will be doing your mouth. I'm just gonna feel your lips on the outside. Firm, open your mouth. Lips are pink and moist. Open wide for me. I have to look at your, so, okay. All teeth are present. There's no cavities. Stick your tongue out like ah, ah, okay. The uvula is midline, no, without deviation. There's no tonsils because she did a tonsillectomy when you were 11 years old, right? So there's no adenoid, there's no tonsils. The tongue is flat with no lesions. Can you do your tongue from side to side? Okay, good. All right, so we assessed the oral mucosa. We did the nose, the ear. Okay, so we're done with that, okay? All right, so next we're gonna do, I'm gonna do your chest, okay? Okay. So I'm gonna look at your chest, and her chest is symmetrical, rising evenly. and I will be listening to your long sounds, okay? Okay, all right. So you're gonna take some deep breaths for me, okay? These are bronchial sounds, and this is where we hear expiration is greater than inspiration. In, out, in, out. Bronchovesicular sounds where inspiration is equal to expirations. In, out. Okay, these are all vesicular sounds where inspiration is greater than expiration. Okay, all right, you're going to turn to the back this way for me, Olivia. Okay. Okay, let me see if my instructor can see. Turn all the way. Okay, good. Okay, so we're going to listen from the back as well. Take deep breaths, deep breaths, deep breaths. And I'm using the diaphragm of the stethoscope, okay? In, out, in, out. Okay, all right, stay in this position. I'm gonna percuss the lung fields. We should hear resonance. Okay, gonna turn
Using
around.
my pen light, I'm going to look at her pupils. Both pupils are round and they are about 4 to 5 millimeters, which is within normal range. I'm going to now check your direct and consensual light reflex. So just please look at me. Good. 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 So she has both direct and consensual light reflex in both eyes. Now I'm going to have you look at my pen, and without moving your head, just keep watching my pen, okay? Good. So both eyes accommodate to convergence. They both dilated as I move the pen closer. So these findings would confirm Perla that the pupils are equal round, reactive to light, and accommodating. Now I'm going to check your conjunctiva, your cornea, and your sclera, and your iris. I'm going to do this by pulling down on your eyelids, and you're going to look up, and then vice versa. I'm going to pull them up, and you're going to look down. Okay? Good. Conjunctiva are pinkish red, which is normal. Sclera is white. I see no corneal abrasions, no signs of cloudiness of the cornea. Good. Now I'm going to check your corneal light reflex. I'm going to do that by shining the light in both eyes and making sure that the reflection is in the same spot in both eyes, which they are. Good. Now I'm going to perform EOM functions using these 6 cardinal positions of gaze. Without moving your head, please just follow my light. Good. Good. And now, using my ophthalmoscope, I'm just going to look at the cup and her macula. Just please try to be still. Good. So her cup is yellowish white and the macula is dark and even in tone. So 3 older adult findings for the eyes would be decreased vision or loss of vision, lack of tear production, and drooping of the lower eyelids and upper eyelids. So the next part will be your nose. I'm going to ask you a few questions first. Have you noticed a change in your sense of smell?
No.
Any history of surgery on the nose?
No.
Any redness, swelling, or discharge?
No.
Good. So upon inspection, the nose is symmetric, midline to the face. Nares are also symmetric. No signs of redness, rashes, lesions, or anything like that. Now, using my ophthalmoscope again, I am going to ask you to look up so I can inspect the inside of your nose, please. So the mucous membranes of the nose are intact and moist and red. No signs of any lesions, discharge, or foreign bodies. Do you feel any sinus pressure?
No.
Good. All right, I'm going to now palpate your maxillary and frontal sinuses. Just let me know if you have any pain or tenderness. Anything there?
No.
No, good. Now, using my pen light, I'm going to look for transillumination of the frontal sinuses. Good. So I see a red halo, which confirms that there is no congestion in the sinuses. Now, I'm going to pass a cotton ball across your nose. Tell me if you smell a scent, and then what scent it is if you do. Close your eyes. Okay. Do you smell anything?
Yeah.
What do you smell?
Mint.
Good. So that was to confirm her olfactory nerve, cranial nerve number 11. Cranial nerve number 12, I'm sorry. Which is clearly intact. Do you have any questions so far?
No.
Good. So, 3 older adult findings for the nose would be enlarged nose, ptosis of the nasal tip, and decreased mucus production in the nose as well. So the next part of the exam is going to be the mouth and the throat. I am going to be using my pen light to observe the internal structures of the mouth. Have you noticed any change in your sense of taste?
No.
Have you had any trouble swallowing or chewing lately?
No.
Have you had any bleeding gums in the past? No. Beautiful. So using my pen light, I'm going to look inside of your mouth and check on the internal structures. Please say ah. Good. So upon inspection of the inside of her mouth, I see that the teeth are white and all intact, no signs of dental caries or plaque. I see that her tonsils are at the 1+ position, which is in normal range. Her tongue is pink, moist, and even throughout. Her oropharynx is clear with no signs of redness, exudate, or inflammation or infection. Uvula is midline to the mouth. Good. Okay, good. So now I'm going to ask you to stick your tongue out and move it from side to side. Good. And that tests your cranial nerve number 12, which is clearly intact because you were able to do that. Good. All right. So 3 normal expected older adult findings would be decreased saliva production, tooth loss, and decreased sense of taste. Now the next part of the exam is going to be your neck. Have you had any trouble, any limited range of motion recently? Any history of surgery on your neck?
No.
No. Any difficulty swallowing?
No.
Good. All right, so to check on your neck, I'm going to palpate your lymph nodes. I'm going to palpate your preorbital, your posterior auricle, your occipitals back here. This is your submental, submandibular, jugulo-digastric, superficial cervical, posterior cervical, deep cervical, and then please shrug your shoulders up. And then your subclavicle lymph nodes. All lymph nodes are not tender, swollen, or inflamed in any way, which shows no signs of tenderness. Do you have any questions so far?
No.
Good. 3 older adult findings in the neck would be stiff neck, curvature due to kyphosis, and wrinkling of the skin on the neck due to elasticity. I'm now going to check your ears. Have you had any change in hearing lately?
No.
Have you had any pain in the ears lately?
No.
Have you ever experienced any vertigo or spinning of the room? Good. Okay. So upon inspection, this is also going to be my thumb-scope. So upon inspection, I can see that your ears are equal in size bilaterally. I can see that they're the same skin tone as your face. I see no redness, swelling, or lesions on the outside of the ear. Now I'm just going to ask you to turn to your right a little bit, and using my otoscope, I'm going to pull the pinna back and insert the ophthalmoscope with my pinky finger bracing it, and I'm going to insert it without, and then bring my eye to it. Good, and then the other ear, please. Good. Good. So upon inspection of the internal ear, I can see that the external canal, the outer canal is intact, no signs of otitis externa, no redness, swelling, or scaliness to the canal at all. I can see that your tympanic membranes are both pearlish gray in color, and no signs of discharge or exudate within the ear. I see no signs of cerumen impactions or foreign bodies within the ear. Your cone of light on your left side is at 7 o'clock, and your cone of light on your right side is at 5 o'clock, which is within normal limits. Now I am going to perform a test to test for conduction of the ear. I'm going to do that with my tuning fork, which I'm going to strike against my leg, hold it up against your ear. You're going to tell me when you can stop feeling it, and then I'm going to move it to in front of your ear, and then you're going to tell me when you can stop hearing it. Okay?
Okay. I don't feel it anymore.
Good. All right, so the fact that you can hear it longer without the bone shows signs that you have greater air conduction than bone conduction, which is within normal findings.
Over your kidney, I'm just gonna give a little. Any pain?
No.
Any pain?
No.
So CVA tenderness was negative. And I'm gonna percuss. So with the lung fields, percussion should be resonance. If it's hyperresonance, it could mean high areas filled with a lot of air, like seeing this in COPD or emphysema. And dullness could be consolidation, and flat is usually the bone. So I'm gonna start by percussing, okay? Okay, so percussion was resonance over the posterior chest. And now I'm gonna auscultate, okay? I'm gonna go over your posterior chest again. On the auscultation, the sounds should be bronchovesicular in the mid-scapular, and everything else should be vesicular. And what we're looking for are adventitious sounds like crackles and rails. So just give a little bit of deep breath when I touch your skin with a stethoscope, and then just let me know if you feel dizzy or anything. Okay, perfect. So lung sounds are clear on the posterior chest. Now I'm going to check for bronchophony. Every time my stethoscope touches your chest, please say 99, okay?
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Perfect. All right, so bronchophony was negative. And so you can turn this way now so I can see your interior chest.
Okay.
Perfect. And on anterior chest, I'm looking for symmetry. So chest is symmetric bilateral. I'm looking for retractions, and I don't see any. There's no obvious injuries, masses.
and respiratory rate is about 16, which is normal. Adults are between 12 and 20, and it's a regular rhythm. There's no bulging of intercostal spaces or any other abnormalities. So I'm gonna start palpating and just let me know if there's any pain, any tenderness, any pain. Okay, perfect. And I'm going to percuss the anterior again. Resonance should be the sound that I could feel, you know, the percussion notes. And dull is usually over the heart or consolidation, okay? Okay. Okay, so resonance over the anterior chest. Now I'm going to auscultate, and on the anterior chest, bronchial sounds should be heard over the trachea, bronchivesiculars in the middle, and then everything else should be vesicular sound. And again, adventitious sounds that we usually look for: wheezing, or wheezing, crackles, rails. So now I'm just going to auscultate, okay? Deep breath, a little bit when I touch, okay? Okay, perfect. So lung sounds are clear, and then we have aortic valve on the second intercostal space on the left. We have pulmonic valve on the second intercostal space on the left sternal border. Herb's point, third intercostal space on the left sternal border. Tricuspid valve, fourth intercostal space on the left sternal border. And then we have the mitral valve on the fifth intercostal space, mid-clavicular line. The apical impulse is best heard on the fifth intercostal space, mid-clavicular line, when the patient is laying down. So now I'm gonna, when the patient is laying on the left decubitus position, and if that's displaced, it could mean heart enlargement. So I'm just gonna go over your heart round. Actually, before I start, I have to inspect. So right now I'm inspecting for any leaves, heaves, or any thrills, and I don't see any. Can you please lay that way? Thank you. You can lay down. Lay down flat. Yes, okay. Thank you. And I'm just gonna go over your heart sounds, okay? With my diaphragm first. So aortic, pulmonic, herbs, tricuspid, and then mitral. Okay, now with the bell. Okay, no extra sounds, no S3, no S4, no gallops or murmurs are heard. Now can you please lay on your left side? And I'm gonna listen to the same points, okay?
Okay.
With my diaphragm. Okay, aortic, pulmonic, Herb's point, tricuspid, okay, and mitral valve, okay, and now with my bell. Okay, no extra sounds, no S3 or S4 or gallops or murmurs. Go ahead and have a seat. Thank you. And I'm going to ask you to come forward a little bit and then just exhale all the way while I listen, okay? Okay, I'm going to start with my diaphragm. Go ahead and exhale all the way. Good. Okay. Okay, go ahead and exhale. I need to see you exhaling. Okay, thank you.
Mm-hmm.
Okay, perfect. Now go ahead and exhale again. I'm gonna listen over your carotid artery. Okay, perfect. So there's no extra sounds for any S3 or S4, no gallops murmur over the heart, and then there was no worry over the carotid artery. One thing I missed was if you could just lay down again, please. Just checking for thrills or heaves over the areas with the palm of my hand. Neck, herbs, tricuspid, and then mitral. And there were no heaves or lifts.